Welcome everyone to the Health for the World International Grand Rounds. Our Grand Rounds speaker today is Dr. Prachi Dubey. Dr. Prachi Dubey is a neuroradiologist at Houston Methodist Hospital and Houston Radiology Associates. She's also an adjunct assistant professor at Texas A&M Health Sciences Center, College of Medicine. Dr. Dubey is a renowned neuroradiologist and has a very interesting topic, especially in these times. Dr. Dubey will be talking about advanced imaging utilization, disparities, and impact on emergency care. Is progress going from bench to only some bedsides? Thank you so much, Dr. Dubey, for doing this for us, and you can start whenever you are ready.
Hi, everybody. I can't see you all, but I can imagine your bright faces and different continents that you might be in. I'm speaking from Houston, Texas, and it's 9 o'clock Central Time here in the morning. And I wanted to first thank Dr. Rehani because she really truly exemplified this image. So I grew up in India, and then, in my early 20s, I made the transatlantic journey into the United States. And in my middle school, 6th grade to 10th grade, this was the school motto, Vasudhaiva Kutumbakam. And this sort of has become a part of my existence ever since. It has really stayed with me. And what it truly means is the world is a family. And Vasudha means earth or planet, and Kutumbakam is family. So with what Dr. Rehani is doing, in her mission, kind of exemplifies the principles behind Vasudhaiva Kutumbakam. And I'm really, really grateful. As I was just telling her before the talk started, I'm truly grateful to contribute to this mission. So thank you for inviting me. So the key objectives for this talk today are to review what are the patterns of advanced imaging use in the emergency department. And I'll tell you a little bit of why we are focusing on emergency departments. As physicians, all over the world, ED is a big part of what we're doing. We're going to look at recent trends of advanced imaging, which basically means CT, MRI, and ultrasound. Because I'm a neuroradiologist, head CT is a particular interest of mine. So we're going to then distill down to head CT and see what are the trends of head CT utilization in the ED. What are the patterns, which patients are getting it, which patients are not getting it. And then ultimately look at some of those disparities with the light of how we can improve those disparities. And that's, I think, where your experience comes in very handy. And after the talk, through email or through Dr. Rehani, I would love to hear your experience and your stories, because I'm sure you're living the disparities I'm going to be talking about. And then because I'm a radiologist and radiologists love to show educational cases, there's going to be a very few cases at the end, just as examples of some of the common head CT things that come into the emergency room. Thank you so much. And here we start. So the key objectives that I just talked about are ultimately going to lead us to our ultimate goal. At the end of this talk, I don't expect for us to have solutions or concrete answers. But what I do want is to start a dialogue, a channel through which we can exchange ideas, share knowledge, seek knowledge, inspire each other, and hopefully get to a better state than the state that is depicted in this cartoon. Why did we choose ED for today's session? The most fundamental unit of healthcare services is to make sure that everybody is getting access to life-saving emergency care services. No matter where you are, no matter who you are, what your ethnicity, demographics, background is, the life-saving critical care services should be accessible to everybody in the ideal world. That's the goal. And ED forms a fundamental unit of that process. And therefore, I wanted to first talk about the emergency services. And available 24/7 is the reason I put that in there, that there's certain, at least in America, there are certain avenues where you can access healthcare services, but they don't have to be 24/7, and we call them urgent care. I'm not sure if you have similar, sort of variations of urgent care in your practice or in your system, but in America, we do have urgent care. However, for the purpose of this discussion, I'm going to focus on the ED, which is basically available 24/7. We're going to talk about whether this is going to be accessible to people, not just accessibility, whether the treatment they're able to get in these EDs is appropriate and adequate. You get the appropriate antibiotic, but you don't get enough of it. And that's not going to be good enough to achieve the outcome we desire. Ultimately, cost has become a big issue in United States of America, and I'm sure it's a bigger issue in some of the other parts of the world where you have limited resources to begin with. And one of the things, when we translate bench to bedside, we not only have to make sure that we are disseminating bench to bedside uniformly, we have to make sure that we do it in a practical and a cost-effective manner. And the last thing that I wanted, it's an E that I added, is basically equity. As you know, as you saw from the slide before, there's so many obstacles we need to overcome, and these obstacles vary based on who you are. So you, despite having all the avenues available to you, you may not be able to access them appropriately because of this disparity in health equity. So these are the components that we're going to discuss today. So here I'm gonna just remind us what health is. I hope you can see this and this is not being blocked by some of the webinar panel. So health is a state of complete physical, mental, and social well-being, and not just absence of disease. So while ED is going to be involved in fixing some of the emergent problem, the spectrum of health goes beyond that. So looking at the ED doesn't mean that we're addressing the whole problem. We're just looking at a small snippet of the issue. Preventive medicine is extremely important to truly achieve the absence of disease and infirmity and the presence of physical, mental, and social well-being. So this has been there. This is the preamble to the Constitution of the WHO, and it's been there and still a goal. It's sort of a moving target. It's a goal we need to achieve. And this is something that I really wanted us to sort of go back to and revisit. We all have seen this before because this is a part of the Constitution of the World Health Organization. And as you can see here, is the enjoyment of the highest attainable standards of health is one of the fundamental rights of every human being. And that is why equity becomes extremely important for us. All right. Now, some of you might be wondering, what is this DTI cartoon doing in a health equity, disparity, and access talk? And the reason this DTI cartoon is there, first of all, I was involved in DTI, and it has been something that fascinates me. This is a paper, which is sort of a technical paper on explaining the principles of DTI. And I found certain similarities, certain analogies that I could draw to just a bigger scale. So here you can see that a doctor examines a patient and finds, let's say, hyperreflexia or something abnormal in his neurological exam. Patient gets a head CT, you get some information. Patient gets an MRI, you get some information. Patient gets a DTI, you get some more information. And DTI refers to diffusion tensor imaging. For those of you who might not be very familiar with it, I'm going to tell you a little bit about it. And then ultimately, this is the cartoon on the end in the lower bottom, where you're sort of somewhat looking at not really a true picture of reality, but the closest picture of reality on gross anatomy. Is this true picture of reality? I wanted to just point out that no, not really, because there is more complexity and granularity even on this picture, because you have more molecular information, you have more microscopic information, but something similar to that you're seeing here. You see a big giant blob. So clearly this is missing some information compared to, you have more detail, more spread out fibers here. You have no fiber orientation here. Here, at least I know that these blue fibers are going up and down. Doesn't matter whether it's going up from bottom to top or top to bottom. It doesn't give you that, but at least it tells me a general direction. So I'm losing information as I'm going from the reality to all the way to the patient. So somewhat information is lost in translation, and we all know that it's an intuitive concept. We experience that and we accept that, and that's fair. This here, I think of it as like my cone of translation, and the tip of this cone becomes narrower and narrower, and it takes longer and longer for really information to trickle down to the actual person who's being impacted. And the goal with what we are doing today, or what we're going to be sort of thinking about, is to kind of chop this tip off and get it to a point where we can create somewhat of a barrel of translation instead of a cone of translation. All right, so we're going to keep moving. So is it even possible to create somewhat of a barrel, if not a perfect barrel? Is it even possible to take something completely from bench and take it to bedside, but not just some bedsides, translate it in a fashion that it can be scaled at large population levels and not help few people, but help humanity? Is it even possible to do that? I think the answer is yes. And it's not an optimistic yes, it's a pretty realistic yes. It's because, pulse polio immunization program is an example that I have witnessed. As I told you, I grew up in India. I did my medical school in India in the, late 90s to early 2000s. Now, as Dr. Rihani probably can tell you, and other people who've trained in that time can tell you, that in the late 90s to early 2000s, there was the pulse polio immunization program that was launched in India. And even though you were not an expert in epidemiology or community health sciences, just by virtue of being a medical student or a resident or an intern at that time, you did get involved in pulse polio immunization program. It was like a all hands on deck approach. And I happened to be a part of that. And I did see that these vaccines, which were created in the 1950s, the Salk vaccine, as we know, was injectable. And then the Sabine vaccine, we know, was the oral form. It's a little bit easier to scale and operationalize this vaccine because, you don't need a lot of expertise to drop a few drops inside somebody's mouth. So that in the 1950s was operationalized in the early 2000s and then led to eradication of the wild polio strain in India, with the last case reported in 2011 and ultimately India being removed from the WHO list of countries of actively endemic wild polio virus transmission. And notice I said wild because there might be a few sort of trickling cases which we believe are felt to be vaccine-related disease. And therefore, they're trying to switch out of OPV to the IPV format. But nevertheless, we were able to do all the three components of translation that I'm talking about in this talk. Invention alone is not enough. It's good for your patent and your vanity and your glory, but it's not good enough to really do what you intended to do as a scientist. Application is important, and we have application experts and we owe them a lot. But ultimately, I think I noticed that this is where things are sort of falling apart. We need more operational leaders, and Dr. Rihani is one of them, who can take an idea, scale it, make it practical, translate it in an easy format where people can truly benefit from it. So, this is one example that comes to mind. And as a neuroradiologist, how can you not talk about diffusion when you're talking about translation? I think this is an invention that has touched many people, many patients across the globe, and is a very good example of how a good idea can completely transform the way we do medicine. Back in the day, without diffusion, it was hard to figure out which one is the acute stroke. It was, took time on CT to really see it. Even on the conventional T2 flare sequences and T2 sequence, it was just took longer to see the actual acute stroke. But with diffusion getting as good as it is, you can see it as quickly as within 45 minutes. This is an initial experiment by Dr. Mosley. I just happen, every time I read about the work that they have done, I get goosebumps, and I'm sure it affects you the same way. So this is when they had initially done the experiment in cats, and they did 8-hour post-occlusion images. And as you can see, this is the very, very low B value, around 17. And then he increased the gradient strength. This is a higher gradient strength. And as you can see, this can show you the infarct very well. This here is the apparent diffusion coefficient, derived from this and this, which is your low B, essentially the B0, and this is your high B, and the ADC was derived. And you can see the stroke with slow diffusion here very, very well. So this is 8 hours. In the same paper, they sort of pushed the envelope a little bit further, and they did 45 minutes. So as you can see, my bracket here for invention and application is getting bolder, because we did it in 8 hours, then we pushed the envelope, and we were now able to do it in 45 minutes. I mean, we as in Dr. Mosley's team, obviously. And then you can see that you can still see the stroke, and it's beautifully seen, and it wasn't possible before. The scanners got better, the technology got better. This is how it was applied in a patient. Notice the other images I showed you were in cat. Subsequently, this later paper was published in Annals of Neurology, again with Dr. Mosley's team, and they were able to reproduce the results in patients. And as you can see the acute stroke very easily. Here again, you see the acute stroke very easily. Here you have an acute stroke and you have a chronic stroke, both on the same image, and you can differentiate them because only the acute stroke is positive on ADC and DWI. the images look very grainy, and you're like, what, this is how they used to read MRIs before. But, believe it or not, when we started, we didn't have such high in plane resolution, and there was a lot of noise, so the SNR was very low. So here we have now a image from a more recent DWI, and you can see the difference in quality. So in terms of invention and application, we have really, really gone a long way with DWI and stroke imaging. But I do still believe, even though there are some operational successes, but the operational successes are not uniform, I do still believe that it's not easily available to all patient populations, particularly those who are in the rural areas and impoverished areas. So I changed from lost in translation to stuck in translation. Somewhere there is an operational bottleneck, and together with our efforts, we should be able to widen that tip of the cone and make sure that we can adequately disseminate the progress that we've made to everybody. So this is a paper which sort of looks into, what are the resources available. And again, these are, most of the papers that I'm going to be talking about today are population-based or derived estimates from a national database. Either it's a pair database, or it's the NEMICS database, or it's the NEDI. But I really definitely wanted to get a bird's eye view of looking at bigger trends nationwide. So here again, they're showing that ED accessibility to CT imaging is nearly universal in the US. Now that might not be the case in your country. I'm sure that's not the case in many parts of India where I come from. So I completely understand that this may not, still be a reality in many parts of the world, and the goal is to make it a reality. The resolution of CT, however, may not be, you might not have the 32, or you might not have, the fast scanners that you have right now. We have a 128 slice scanners. We know that we even have 256 slice scanners, but some of these are not, that fast scanners. So the speed may not be very good. The resolution of these CTs may not be very good. We may not have access to MRIs in many of the EDs. And the characteristics of the locations where we didn't have CT or high quality CT, especially you need this high quality CT for perfusion imaging, and MRI, as we saw, DWI is really very helpful for detecting acute stroke. Even though we have perfusion, but I still feel DWI sort of, it's just nothing beats it. So the characteristics of the locations where you don't have access to CT and MRI are places who have lower volumes. They are in rural or remote locations. And this is affecting the availability and quality of imaging, which is in turn affecting the timely diagnosis. And in terms of MRI, I noticed that the authors found less than 10,000 annual visits was basically the sort of inflection point in terms of volume, that if you had lower than this, you really didn't have the resources. And I'm pretty sure it's the economics of financing this when you don't have enough volume to meet utilization. Rural hospitals, critical access hospitals, non-teaching, non-stroke, and non-trauma centers. Okay. So we keep going, and then we talked about resources on the previous slide. Here we are going to talk about the pair mix. Now this is another paper by Dr. Walid Brinchki's group, and they showed that in acute imaging, acute stroke imaging, patients' insurance status or what their payer status was also paid in, also played into whether or not they were able to access advanced imaging. And here I'm talking about CT-MR angiography, MRI, and echo. You notice I'm not talking about non-contrast head CT, because non-contrast head CT does get utilized pretty evenly. And I'm doing some more work in the NEMICS database to really verify if that truly is the case. And it preliminarily, it sounds like that might be the case. However, we know that insurance status is definitely affecting the utilization of CT-MR angiography, which is your vessel imaging, and MRI and echocardiogram. With the uninsured Medicaid patients and Medicare patients having significantly lower odds ratio of these imaging tests being utilized for their workup. So now we talked about there is disparity in availability of the tools. There is disparity in utilization of available tools based on what your pair mix might be, what your demographics might be. But do these disparities really lead to an adverse outcome? You don't have to. It's very complicated to address imaging in terms of disparity, because imaging is not a disease or a health condition. It is sort of a surrogate marker of it. So the next question one wants to figure out is it really affecting anything? Does it make a difference? So there've been papers. Now, I don't have exact outcome measures precisely to tie one story together, but there's papers on MTBI literature. And this is one paper that I saw, which had information both on the survival trends in the lung cancer patient and use of MRI. In terms of socioeconomic status. So patients who had higher socioeconomic status had a higher overall survival and were more likely to have used MRI in their diagnostic workup. Now, how much of this contributed to this is something we won't know for sure, but at least there is a sub-story behind the overall story. And it's important for us to make sure that the needed diagnostic imaging and interventions is sort of more uniformly available. This is another commentary that I really like. Both of these, Dr. Levine and Dr. Dusak are sort of the, big voices in the field of imaging operations and utilization research and disparities. And they sort of address the same question in an editorial in JAMA, where they're saying that, it's not just imaging. Imaging has direct impact on outcome, as we saw in the slide before. They showed here, and I encourage you guys to read the whole commentary, atraumatic headache and abdominal pain CT in the initial ED visit lowers your revisit to the ED. It reduces the rate of you having to come back to the ED again. Advanced imaging such as CT ultrasound even impacted a length of stay again, the references for each of these articles will be given in this editorial if you refer to that, and I'm happy to share it through Dr. Rehani, that it impacted the length of stay in the hospital. How long you're in the hospital can be shortened if you got imaging on the day of the admission or the second day of admission. Then again, blunt trauma, blunt abdominal trauma, we all do fast ultrasound for this. We do CT when it's available. And when you're doing CT and it's available, it gives you a better understanding of how much visceral organ injury is there. And you may have to avoid, you may be able to avoid exploratory laparotomy. Same thing, CT and ultrasound rates reduce the rates of negative appendectomy. So imaging does not only, it's not just disparity in imaging, it can actually lead to disparity in outcomes if they're not available where they need to be. So bird's eye view, as I talked about before, I'm interested in looking at, what the big trends are. And as I want to remind myself, no matter what the bird is, how good the bird is, even if the bird is a satellite and has a really big perspective, it's still a perspective. So I want us to remember that bird's eye view will still be a perspective based on where you're looking at. So in the few slides that are coming, I'm looking at a specific survey. So, my perspective is that survey with its flaws that we must always keep in mind. So it's the National Hospital Ambulatory Medical Care Survey, or NEMEX, and this is a nationally representative survey, and it's an estimate because it is basically extrapolated from a trained interviewers gathering data using survey sheets in randomly assigned 4-week reporting period. And then there's a complex design, and there's a reference. I can again refer you to that, and how this is extrapolated using weighting to create a probability sample or an estimate of the nationwide numbers. So this is one of the important papers that was published in this area by Larson et al. In radiology. And, it's showing the ED visits in millions. And as you can see, there's, been a sort of a creeping upward volume of people accessing the EDs over the years, which, may be a good thing because that might mean that the ED services are more available and accessible to people. And then I added, I, in the sense that our group here, we worked a little bit more on the data that was available after 2007, and we were able to add information between 2007 and 2014, and kind of we see a same upward, very slow. It's not a steep curve, but there is a sort of an upward slope, going on since 1995. So this is the published data, and they're showing that their CT utilization has increased pretty exponentially over the years. until 2007. And again, to this as well, we added our own data, and we noticed that after 2007, there seems to have been some stabilization, at least based on this perspective, on this data set that we're looking at. Well, it may not translate into every other data set, but definitely here we did see stabilization. There was a little somewhat of a peak between 2008 and 10, but then it sort of, trended down. So overall, since 7, there has not really been a significant change in terms of the volume of utilization. Now I'm gonna, because this is a big time scale to look at, I'm gonna focus only on this area. And this is what we see when we focus only on this area. Our CT utilization based on the NEMEX data has sort of remained stable since 2007 to 2014. We're still analyzing more information beyond this point, and that is not available for me to talk about today. But as you can see, it has kind of stabilized. It's not as much of a peak as was shown in the Larson et al. Paper prior to 2007. And because head CT is a particular interest of mine, or neuroimaging is a particular interest of mine, I looked further into neuroimaging and head CT utilization, and that also kind of looks like it's pretty steady. Okay, so we're going to dive more into head CT. It's a very important study in the ED. After I graduated residency, I started my life as an ED radiologist, taking these ED shifts where I did sort of everything. And head CT, all comers is really a very commonly used study. And that is not just an anecdotal experience, it's actually backed up by data. And you can see it's, pretty much 50% or every other study is a head CT in terms of all CTs. Why are head CTs being done? Most commonly, it's trauma, headache, and vertigo. And that trend of using head CT for these 3 conditions, trauma, headache, and vertigo, has not changed over the past 7 years. That really has still been the top 3 uses. The bottom uses, sort of keep changing. There is some variability, but definitely for the top 3, it has been a pretty consistent theme. Did we see disparities? Since we talked about equity before, yes, we did see disparities. Now, some of the interesting disparities, I do realize that, with age, there's more utilization, and that may be intuitive as a result of comorbidities and, susceptibility to a more severe injury with minor trauma. There are some other, despite adjusting for all of the other factors, there are some disparities that still continue to emerge. Race was one of them. We talked about payer mix, and again, payer mix is again one of them here. And then rural location was another one where there was some significant disparities. Now, this is a more recent paper that was done by Zhang et al., which came out, and they are looking at ADI in a different database, advanced diagnostic imaging utilization. And they did notice that 30% of the ED visits did result in ADI use, or advanced diagnostic imaging use. And then out of these, 17% were CT, 3.6% were ultrasound, and 0.4% is MRI. So you can continue to see that this number here is really very small. So the numbers of patients who are getting MRI remains really small. And we touched upon it before, that it's just the availability and access to MRI, particularly during the night and the evening hours or in remote location, remains an obstacle that we need to overcome. And 1.2% of the patients get multiple types of imaging. Did they see disparities? Well, they also saw disparities. And again, they saw disparities related to race, residence, and insurance status. African-American population gets a significantly lower use of ADI. Homeless population gets a significantly lower use of ADI. You can see the odds ratio is 0.54. It's pretty significantly low here. And then we're talking about insurance status, where we notice that the patients getting Medicare, Medicaid, and uninsured patients are lower use of ADI. Disparities. So what are disparities? I want to point out here preventable differences. So this is what we're talking about. We're not talking about things we can't change or we can't help. Older people are more prone to getting diseases. That's not a preventable difference. Patients who are immunocompromised are more prone to get infections. That is, again, not so much of a preventable difference. But what are the obvious preventable differences that we can eliminate? And we should be at least identifying them, articulating them, and trying to eliminate them. So preventable differences in the burden of disease, injury, and violence. And why did I highlight opportunities? Because I feel even though imaging does not mean disease, does not mean injury, does not mean violence, but could imaging be a part of this component, which is opportunities? Having access and availability and being able to utilize the entire spectrum of diagnostic tools that is out there is an opportunity that might help us achieve optimal health. So I do feel looking at imaging in terms of disparities is important for its, for what it's worth, but most certainly has to be done in correlation with the overall outcome. What is socially disadvantaged? Well, that's a really loaded term, and I don't think I will be able to address that term or do justice to what it really means in this short topic, in this short talk. But some of the big players that we think about when we're talking about socially disadvantaged populations is race, ethnicity, gender, education, income, disability, geographic location, as we saw the rural areas, sexual orientation, definitely with the LGBTQ community. So this is sort of a broad view of what social factors might be under consideration. Now, is there anything we can do? That's where I'm coming to now. Is there anything that's even possible to be done to address these problems? Now, while there are many things we can do, I think one of the things that just is very striking, and I have seen in a few papers, is guidelines. So this is a paper that is by, the group in Brown, Dr. Chu. I don't know if you guys are very, sort of active on Twitter. You might see her. She's quite remarkable, very knowledgeable. So lack of gender disparities in emergency department triage of acute stroke patients. So they saw there were absence of gender disparities. And what they concluded was that having ED triage protocols for stroke patients may be effective in minimizing gender disparities in care. So here we have a ray of hope that when we have, now it doesn't mean that this is always the case, because there are certain other guidelines, and I saw some contrary papers with ACES guidelines, that it doesn't always translate into removing disparities. Despite guidelines, we might have disparities, but at least if we have guidelines, there is one step forward towards making sure that we have fewer disparities. Then it comes to the second component of making sure there is compliance with guidelines. But having guidelines, I think, is extremely important and very, very helpful in trying to eliminate these disparities. So we keep going further. This is another ACES, advanced accelerated chest pain evaluation with stress imaging, where protocols were able to eliminate testing disparities. There were no disparities in outcome here. I want to point that out, but definitely it was able to eliminate testing disparities. They saw that patients who went through the usual care pathway got 3% cardiac catheterization in African Americans. And in the patients who went through the ACES of care pathway, the testing rates did not differ by race, 98% versus 99%. So at least two papers, I was able to point out that having guidelines, having clinical care pathways with specific steps of workup can help us eliminate some of the disparities that might be emanating from implicit bias. I totally agree that will not address the complete absence of resources. So here's like this little bit of sun coming out. Can guidelines mitigate disparities in utilization of necessary diagnostic test and treatment pathways? And my answer is a probably yes. It's a big P here. And will this positively impact disparities in overall health outcome? And I have a small probably yes here. It probably will, but that's not the whole story. As I said, workup is only a part of the patient's care. And unless we address the patient's care in a holistic fashion, we may not be able to completely overcome disparities, but definitely this is a part of it, and an important part of it that we should be focusing on. Now, what is the ACR doing, or what is the CMS doing? So ACR, which is the American College of Radiology, has done some tremendous work in this area. And I really want to congratulate the leadership and the governance body for really achieving that. So the CMS, which is the Center of Medicare and Medicare Services, they came up with the Protecting Access to Medicare Act, or PAMA, in 2014, which really what it means is it requires a certain concept consultation before we are using advanced diagnostic imaging. So it's called sort of giving the clinicians a guideline as to when it may be appropriate to use a certain imaging test while they're working up patients in the ED. So this is called the appropriate use criteria program. So again, here I'm telling you that the ADI will require consultation. So it is sort of, it's legislated that you will need to consult with a qualified clinical decision support mechanism before you can order the advanced diagnostic imaging. Now, right now in 2020, there is no penalties, but going forward, there may be payment consequences as a result of this. And what is the clinical decision support mechanism? These can be electronic softwares or tools that will be embedded into your software, your ordering system. And I know that many of you may not even have that. So this might be more of a paper consultation if you want to implement this in your practice pattern. But here in the United States, many ordering systems or requisitions, portals can be integrated with CDSMs. And while a physician is ordering a certain test, he can consult and get guidance as to whether that test is appropriate or not. If you want to get more information on what is the appropriate use of imaging, there is free resources on the American College of Radiology appropriateness criteria. I happen to be a part of the neuroimaging panel this year, and I know the amount of work that goes into coming up with these evidence-based guidelines. It's really, really helpful. It's a rigorous process, and feel free to use this in deciding and even implementing in your practice wherever you might be. I used head trauma here as an example because we saw that head CT is 1 and 2 studies, and we also saw that trauma is a big reason for us to be doing it, and it actually is actually the most common reason for us to be using head CT in the ED. And here you can see when you fit the nexus criteria or the Canadian CT head rule, which is CCHR. And if it's appropriate on that, then CT head without contrast gets a rating of 9, which 9 here really translates to usually appropriate. So with the end of this talk, I think we're doing pretty well on time. We actually might have a lot of time left over for discussion. I was told 40 minutes, so we're going to be done in the next 4 minutes. We'll have enough time to talk to each other and share our stories. I'm going to show you some very common cases, nothing extraordinary, some bread and butter cases that come to the emergency room and where a head CT is used. So here it is. There is a case where I'm showing you a non-contrast head CT. And as you can see here, there are 2 things going on. You have this hypoattenuation. This here, right, is the superior part of the temporal lobe. You have some hypoattenuation, which might be a part of the occipital lobe, and you can see that there is this dilation of the atria of the lateral ventricle. So there's some volume loss going on here. There's this dilation, which tells me there's probably some ex-vacuo change. So this is probably an old stroke that I'm looking at. Here, on the other hand, I'm losing a part of the insular ribbon. I'm seeing this hypoattenuation in the frontal operculum. I'm seeing a little bit hypoattenuation is also going into my putamen. So this is somewhat of an acute to subacute infarct. And again, diffusion would help us age the infarct very well. There's no volume loss, so I am pretty confident that this is not a chronic stroke. A part of the cortex is reemerging, which is what we call the cortical fogging. And that happens typically in the subacute state. So we have 2 different ages of infarct on this non-contrast head CT. So here again, this is a non-contrast head CT, and I can see there's a fracture. I can see there's a teeny bit of air going inside the calvarium in the intracranial region, and I see a big lentiform hyperattenuating collection here. This is an epidural hematoma. You can see sort of the swirl sign. A lot of times swirl sign is an indicator of active bleeding, which means rapidly expanding hematoma. Time is of the essence, and clinically in such a patient, we know how critical the availability of having a CT scan is. There is a distractor subgaleal hematoma right here, but really the bigger problem is over here. So this is somewhat of a complicated case. Sometimes it's hard. Things that are high attenuation on CT don't necessarily always have to be blood, and therefore the experience of a radiologist or a neuroradiologist comes handy. So this here is some high attenuating foci. Maybe there's a punctate amount of calcium. There is a little bit of hypoattenuation around it, which could be vasogenic edema. We don't know for sure. contrast, CTA was done, CT angiography, and therefore you know that having these tools available might help you problem solve faster and triage the patient faster, reduce their observation period or length of stay, and it turns out to be a vascular malformation or an arteriovenous malformation in this particular case. So we're going to keep moving forward. And this is another case where we see this multiple comminuted depressed fracture of the calvarium involving the right squamous segment of the temporal bone. There is an underlying contusion. You can see these petechial dots in the underlying parenchyma, mostly in the cortex, but also in the subcortical region. So there is an underlying contusion. Now remember that when you image somebody in the very acute or hyperacute setting, the contusion may not be very obvious and it may declare itself the next day. So always be careful when you have a trauma patient. You may see contusions appear the next day. It wasn't like it was missed before. It just declares itself sometimes a little bit later. The areas that you always want to scrutinize very carefully when you have a trauma patient is the things that can slide over the calvarium's anterior cranial fossa and the middle cranial fossa, and that is your, the inferior part of your frontal lobe. So look always at the gyrus rectus and the inferior frontal gyrus, and also look at the anterior part of your temporal lobes. So just screen your Sylvian fissure carefully, because that's where you can sometimes have the sliding impact injury, and contusions can declare themselves, sometimes in the next day. Okay, so here again, you have a non-contrast head CT, and you can see this hyperdense sign. This is a common sign that we always screen for on non-contrast head CT in stroke patients. And this hyperdense sign is essentially telling us acute clot, and this here happens to be in the M1 segment of the MCA. And again, you're seeing that there is occlusion here. This is a clot that is amenable to thrombectomy. It is very proximal. And this is a right MCA M1 segment acute occlusion. So this patient, we see absolutely no gray-white matter differentiation. You can see some, hyper attenuation along the sulci, but really you have no detail at all whatsoever inside this patient's brain. So there's massive edema here, complete loss of gray and white matter differentiation, really poor prognosis. And as you can see here, there was absolutely no flow intracranially on the angiogram. So this is another patient, comes in with dizziness, giddiness, another common reason for use of advanced imaging in the ED. And here I would like to point out to you that be very slow. Head CTs can be somewhat tedious to read at times, because there can be abnormalities that are very subtle, and it's not always easy to get an MRI instantly. So you might have to look at some secondary signs to solve the problem. So here again, you can see that there is some extra soft tissue density in the CP angle CSF cistern on the right side here. And you can see there is expansion of the internal auditory canal. So that tells me there is a mass here, and you should get an MRI for such a patient so we can figure out what's going on. And this happens to be a schwannoma. As you can see, there is a schwannoma. It is not just in the CP angle CSF cistern as we were expecting from the CT. It goes into the porus acousticus all the way up to the cochlear aperture, distending the fundus, and then there is also some intralabyrinthine extension right here. Okay, this is the team that worked. This is Dr. Khurram Nasir, also my better half, and this is Dr. Anshul Saxena in Baptist Health, South Florida, who sort of helped with the their methods experts, and they helped with the NEMEX analysis. We did consult Dr. Richard Dusak with our initial analysis, and he gave us some pointers, and extremely appreciative, because I know he did that when he was already preparing to transition ACR into the online format. So really very generous with his time in helping people with their scientific work. So thank you again. Thank you, everybody. And now I open the floor for questions. I would love to hear your experiences. And thank you, Dr. Rehani, for having me here.
Thanks, Dr. Dubey. This was excellent. And I really appreciate this. This was a very, very apt talk, especially given the disparities in care at this time. Let me ask, this is a webinar format, to see if anybody has any questions in the Q&A box. So let us give everybody a minute. So if anybody has any questions, can you please post it in the Q&A box? And if not, as always, you can just email us at contact@healthfortheworld.org. What I will make sure is that we'll forward this to Dr. Dubey, and so that she gets your questions so that she can answer them later. And so we'll give maybe 30 more seconds.
Yeah, that's fine. I understand that it's some of them might be on their phones or and very welcome to address anything offline. I would love to be able to hear their experience and their stories and what they are doing in their practice to overcome some of the obstacles we talked about, and also if we can help collaborate and take this further. I definitely agree this is a fantastic platform for exchange of ideas and collaboration, and seeing if we can help each other move forward past these obstacles.
Yeah, no, that's great. And then, as Dr. Dubey is saying, it's not just the questions. Please feel free to share your experiences um, from your countries, and that would be really nice too. We have a feedback from Dr. Teodora Rivera, who says excellent presentation.
Thank you, Doctor.
All right. So I think I don't see any questions right now, which is a good sign. And what we can do, Prachi, is that after this presentation, when we get emails, we'll forward those to you. So I think that
Thank you
will
so much. Thank you so much. Appreciate it.
that'd be really nice. Give me 1 second. Let's see. Dr. Dennis Mosha from Muhimbili in Tanzania says, "Thank you for the nice presentation." All right.
You're welcome.
And Dr. Fatima Ali Omar, again from Mohimbili, says, "Thank you for the educative talk."
You're welcome. Thank you so much for attending. I'm so glad we were able to do this.
All right. And then there's one more person, anonymous attendee. Thank you for the excellent presentation. All
You're
right.
welcome.
I think everybody really liked it. We really appreciate you doing this for us, Dr. Dubey. And we will be uploading Dr. Dubey's presentation online. So please feel free to share it with colleagues who were not able to attend today. All right. So thank you so much, Dr. Dubey, and have a really wonderful day. And thanks so much again for doing this for us.
You're welcome. Thanks, Dr. Rehani. This was a pleasure.
All right. Thank you. Have a good day. Take care. Bye-bye.